The following podcast is part of a certified educational activity titled Therapeutic Advancements in Myelodysplastic Syndromes, Bridging the Gap Between Patient Safety and Quality Care Through the Latest Science and Evidence-Based Learning in Nursing Practice. Access the entire activity and complete the post-test at peerview.com/EQN860. Downloadable slides and practice aids are also available.
Welcome to Therapeutic Advancements in Myelodysplastic Syndromes, Bridging the Gap Between Patient Safety and Quality Care Through the Latest Science and Evidence-Based Learning in Nursing Practice. I'm your speaker tonight, Sarah Tinsley, and I'll be joined by Dr. Curtin and Dr. Salmon. We're going to take a closer look at what the myelodysplastic syndromes are and really what clinicians need to know. You know that myelodysplastic syndromes are a group of heterogeneous clonal hematopoietic cell neoplasms. Yes, we do consider it a cancer. It's characterized by cytopenias. There's also dysplasia, and you can see blasts in the peripheral blood or in the marrow. And there's ineffective hematopoiesis. And there's also recurrent cytogenetic or molecular abnormalities. And for some of our patients, unfortunately, there's a tendency towards evolving into acute myelogenous leukemia. We diagnose myelodysplastic syndromes by performing a bone marrow biopsy and aspiration. And you really want to look at some key items within that pathology report. You want to look at the cellularity, which is the ratio of hematopoietic cells to fat. Unfortunately, our bone marrow becomes more fat as we age, and you subtract your age from 100, and that's what a normal cellular marrow should be. And then for patients with myelodysplastic syndromes, the majority of them have hypercellular marrows, and there's extramedullary, meaning outside of the bone marrow, destruction of the cells. They can evolve into leukemias, and then we also can have hypocellular marrows, and those are more common with your aplastic anemia, immune-mediated problems that impact the bone marrow and make it hypocellular. These are some of the ancillary studies that are very important when you look at a bone marrow biopsy. We do immunohistochemical studies. We do chromosomal analysis. You can see here in the center of the slides karyotyping, where we take those naturally dividing cells and line up their chromosomes to see if there are any structural abnormalities or inversions or translocations. If you have failed cytogenetics by this method, you can perform fluorescence in situ hybridization, but you have to tell them what you're fishing for. So in this case, we're fishing for myelodysplastic syndromes. And we also do molecular testing. At our institution, we use a next generation sequencing gene myeloid mutation panel. And that covers 54 genes that are common in patients who have myelodysplastic syndromes. Let's turn to the incidence of NDS. Overall, the incidence is around 5 per 100,000. It's one of the most common myeloid neoplasms. And we think that the overall incidence may be artificially low because the SEER registry didn't consider this a cancer, and so we've only been capturing this data more recently. And approximately 10,000 individuals per year in the United States diagnosed with myelodysplastic syndrome, and most of those are greater than 60 years of age. So it's a disease of older people. The median age at diagnosis is in the 7th and 8th decade of life. For the most part, we don't know what causes MDS for a specific patient. About 90% of them, we don't know why they developed myelodysplastic syndrome. But we do know that it's linked with cigarette smoking, ionizing radiation, chemicals such as benzene, toluene, xylene, and chloramphenicol. And we have the heavy metals and herbicides and pesticides, and also fertilizers. Unfortunately, for patients who have a solid tumor or another, like a lymphoma, that then develop myelodysplastic syndrome, we link it back to their prior chemotherapy and radiation therapy sometimes. And those are called secondary myelodysplastic syndromes. The way patients present, typically they present with cytopenias, and anemia being the most common. For low platelet counts, we see bleeding, easy bruising, and almost all of our patients have fatigue. That's the most common symptoms. When you look at a CBC with differential, you have macrocytosis or a high MCV, neutropenia, thrombocytopenia, and anemia, as we discussed previously. There also may be signs of hemolysis due to ineffective erythropoiesis. And according to the NCCN guidelines, these are the recommendations for evaluation and diagnosis when you suspect that a patient could have myelodysplastic syndrome. I would like you to really take a look at these and see that you want to check a serum erythropoietin level. You also want to look for RBC folate, serum B12, the ferritin, the iron, and you want to also obtain in your history how many transfusions they've had and at what frequency. And you can see there are also other tests that are considered indicative of nutritional deficiencies that are common for people who've had gastric bypass and people who wear dentures that use a lot of that paste. They can have copper deficiency, and patients on zinc supplementation can sometimes have a CBC that masks or that looks like myelodysplastic syndrome. So let's talk about, go deeper into how you diagnose myelodysplastic syndrome according to the 2016 World Health Organization. So you have to have dysplastic morphology in 10% or greater of the cells, and that you've ruled out secondary causes of cytopenia, excess marrow blasts. And again, you want to look at the whole picture. If a patient has had recent growth factors, that can impact on how the bone marrow looks. So you want to take a good history. Then you look at cytogenetic abnormalities. There are a list of approved abnormalities according to the World Health Organization, and it excludes trisomy 8 and deletion Y, because that can be a normal aging phenomena, and deletion 20q. You can't just diagnose MDS by flow cytometry, because the pathologist really has to take a look at the morphology of the cells. Are they dysplastic? Do they look abnormal? Do they have too many nuclei? Is there budding? Are the megakaryocytes abnormal in appearance? And then the MDS type mutation, we do know that we acquire mutations as we age, and sometimes we're born with mutations, and those don't always tell us that a person has myelodysplastic syndromes. There's something called clonal hematopoiesis of indeterminate potential. So you would observe some of those patients over time just to see what happens with that MDS type mutation. This is now taking a look at the prognostic impact of mutations in myelodysplastic syndromes. Improved overall survival is associated with this SF3B1 mutation, and 14% is how it occurs. 14% of MDS patients have this mutation. And then we have intermediate or undefined impact on overall survival in the second row here. And you can see how those vary, the most common being the TET2 mutations, and then inferior overall survival with the ASXL1, STAG2, RUNX1, and you can see the other ones. One that we'll be talking about later, Dr. Salman will, is the TP53 mutation. So how do we understand a patient's risk in MDS? It often refers to the risk of mortality and AML transformation, and it gives us prognostic information that we can communicate with the patients, their caregivers, and the treating physicians. And really this risk stratification serves as a decision tool to tailor our therapy. We also have different goals when we treat low-risk MDS versus high-risk MDS. And our low-risk MDS is our very low, low, and intermediate, and high-risk is high and very high. And then we want to see, what does the patient really want when they're getting treatment? Do they want improved quality of life, or do they want improved survival? A lot of patients I talk to that I try to get them to prioritize one or the other want both. But some of them really do want improved quality of life. If they want to survive no matter what and be cured, then you may refer them for an allogeneic stem cell transplant. And if we're looking at disease-altering therapies, those would be our azonucleosides. And really, you need to get a complete cytogenetics and NGS panel for all patients to understand their risk level. You can't really put all the pieces of the puzzle together when you have missing parts. We stage myelodysplastic syndromes. There's a couple of staging systems out there, but the most common one used is the Revised International Prognostic Scoring System, the IPSSR. You have to have a bone marrow biopsy result on hand to look at that. And you also need to have a CBC. And you go across down the column here and look at cytogenetics, and then you plug in the person's result from your cytogenetic report and the percentage of bone marrow blasts. Then you work through the hemoglobin, platelets, and neutrophil count. And you can see very low is 1.5 or less, low is greater than 1.5 to 3, and so on. And then, like I was saying, the lower risks are very low, low, and intermediate risk. And then you can see the median survival there decreasing as you get to a higher risk disease. And then in your higher risk category, you have median survival really diminishing quite a bit, with our very high median survival being less than 1 year. So we know that we really have some room for improvement there. But I do think it's important that we talk to patients about what they're looking at so that they can make an informed decision about treatment and how they want to spend their time. If we all knew exactly or kind of got an idea of how much time we had left, we would make different decisions about how we spent our time. And then these are treatment goals. We talk about this a lot at our institution, and also it's the way that we divide our studies up. We have lower risk MDS studies we have clinical trials available for them, and then our higher risk MDS patients, we have specific clinical trials for them. So with your lower risk MDS patients, you're trying to get them to achieve red blood cell transfusion independence, decrease the symptom burden of iron overload. We know that every time they get a transfusion that puts iron in their body, that we don't have a natural way of eliminating that excess iron. So we include them in the discussion about, when their ferritin level is getting at an unsafe level, and just monitoring them, pulling them into monitoring how many red blood cell units they've been transfused with and the frequency. And we really try to aim for improving their hematologic parameters and improving overall quality of life. Whereas in your higher risk myelodysplastic syndromes, you're really trying to improve their survival. If you'll remember, those survival was less than 2 years for our high risk and very high risk. And most of that, or a good portion of that, is due to transformation to AML. So we're trying to alter the natural history of the disease, and you're also still trying to reduce the symptom burden and improve quality of life. I'm a quality of life researcher, so that's where my mind always goes. But if you talk to patients a lot, they talk about, how they want to have an improved quality of life, because just living longer and not being able to enjoy life. It is, they say, what's the point then? I've heard patients say that to me. So this is looking at a European Leukemia Net study with health-related quality of life in low-risk MDS patients, and they compared it with age and sex-matched reference population, and the proportion of problems in usual activities and anxiety and depression is significantly higher in MDS patients, and MDS-related restrictions in their mobility were most prominent in males and in older patients. I'm sure you can think of some patients that come to mind that you've seen this occur with them. And they also have restrictions from their anxiety and depression, and this occurred in females as well. And then patients who were newly diagnosed, we know that they're anxious because they don't know what this means for them and what their future looks like. And the lower MDS patients have a pronounced reduction in health-related quality of life when they're newly diagnosed. So I think as nurses, we help them through that process. We're there for them. We discuss their concerns. We get our social workers involved and other mental health care providers to help them work through some of these struggles when they're initially diagnosed. But really educating them, I think, and getting them in touch with other patients with myelodysplastic syndromes and support groups. And we are using the Prospective International Validation of Quality of Life in Myelodysplasia Scale. There's an NIH observational study for MDS patients that we're using the QALMs for evaluating quality of life, and it's specific for myelodysplastic syndrome. So it's tailored to the disease. Dr. Gregory Abel created this tool. And you can see it goes over the symptoms and then how they impact various areas of people's lives. So that's a very unique tool tailored to the disease that we are using in clinical practice and in studies as well. So in summary, diagnosis MDS can be challenging, but it is a crucial first step. When a person has cytopenias that we really don't know where they're coming from, we really need to work those up and do a bone marrow biopsy and aspiration. And the point mutations in MDS are significant. We have a large body of information that confirms the significance of these mutations on prognosis, but the data is still too immature to determine how to incorporate these into our existing morphologic classification. So it's kind of a blending of the old and the new. So we're not quite there yet, but we are figuring it out. I've seen that during my career at Moffitt, where we didn't always check mutations on everybody, but it's a standard for us now. And integration of these new clinical risk models with the somatic mutations will help us refine the risk stratification in patients with myelodysplastic syndromes. So next, right after this, Dr. Curtin is going to be discussing low-risk MDS. But before we go there, I'm going to start with a case study that then Dr. Curtin will carry on. Kathy is a 76-year-old woman. She was diagnosed with myelodysplastic syndrome. She presented with fatigue and macrocytic anemia that eventually progressed to the point where they had to do a bone marrow biopsy and aspiration to figure out where the anemia was coming from. She had a normal cellular bone marrow, and she had ring sideroblasts and dyserythropoiesis, 3% blasts. Her megakaryocytes, or the platelet precursors, were consistent with MDS. She had normal cytogenetics. She had that SF3B1 mutation. You'll note that she had a normal white blood cell count, a normal platelet count, and the anemia with a hemoglobin of 8.1. With the progressive anemia, she started an erythropoiesis stimulating agent at 60,000 units subcutaneously weekly, and she did not experience a response. So then we look at the IPSS-R that we were talking about, and we can plug her information into this. 46XX is good, so she gets a 1 point. The bone marrow blasts were 3, so greater than 2 and less than 5, she gets another 1. Her hemoglobin was 8.2, so that would give her another score of 1, and so she has low risk disease. So now let's take a look at the nursing implication for managing your patients with myelodysplastic syndromes. We want to really pay attention to their psychosocial factors that influence treatment. If we help our patients, then they can tolerate treatment better. We want to educate them about their disease and go over the goals of treatment and strategies for monitoring their blood counts and their transfusion burden. And then what are we looking at when we look at their labs to really determine whether they need a disease-modifying agent. And we don't want to just look at the patient. We want to look at their whole support system. And also setting expectations. That's really important for these patients. And try to manage their symptoms as much as we can and try to improve their quality of life. So this is an area of research for me. And I think we kind of underestimate the toll it takes on patients. So I don't know if, Dr. Curtin, how do you really focus on the nurses' role in helping patients manage their MDS? What do you suggest for your patients?
I think it's just really important. I have a term I use called consistency of message. I think it's really important for all of the members of the team to really understand where that individual patient is at relative to their disease and what we have in terms of expectations for therapeutic benefit, and then really listening to the patient express their concerns. And many times they're more comfortable talking to the nurses than they are to the physicians or the APPs or others. So really listening and then communicating that back to the team as a whole.
Yes, I like that. What do you think, Dr. Salman?
No, I think you guys have summarized it, really well. I think, so I have a great nurse who's truly an expert, and I think he spends a lot of time, overing all of it, and not just with the patient, but with the family. I think they're often, the patient themselves is overwhelmed on a lot of these initial visits, and they really help walk them through sort of all the other, facets, related to treatment and symptom burden.
Yeah, I agree. The whole team together, focused on the patient and their caregivers, their whole unit. All right. Thank you very much. All right. I'll hand this over to Dr. Sandy Curtin.
Thank you for that. So I'm going to focus on lower risk MDS. So we're going to talk now about low risk MDS. And I think we've heard from Dr. Tinsley in her section about transfusion dependence, and the burden of that transfusion dependence can be significant for these patients. We know that anemia is usually the most common cytopenia present in these patients and is inevitable over the course of their disease. And what we don't often talk enough about is what does that mean to the patient. So we know that there can be a higher increase of dyspnea, hepatic disease, infections, and cardiac events within 3 years of follow-up once a patient becomes transfusion dependent. It can carry an increased risk of death, age-adjusted, compared with other MDS patients, and inferior response to disease-modifying treatment when transfusion frequency is increased. So we know across many studies, those patients who are heavily transfusion dependent, sometimes needing transfusions weekly, often have inferior outcomes when initiating treatment. There are higher health-related costs, inferior health-related quality of life, and then the other thing we really think about is increased risk of iron overload, and you heard a little bit about that in the last presentation. And that's because our body is very efficient at reutilizing iron. Most of us don't need to take additional iron. Really the only way to lose iron is to bleed. And so in younger women who are still having menses, there's some iron loss there. In patients who have gastric bypass surgery, you heard about that in the diagnostic workup there, where they may not absorb iron appropriately, you can actually develop some iron deficiencies. And I always use an example of one of my MDS patients who has had a number of red blood cell transfusions, but her iron studies remained low. And when that happens, you need to start looking for a bleed. And indeed, she had a bleed in the small bowel. It just didn't fit. But for most patients who become transfusion dependent, their iron will increase. And this can affect virtually every organ system in the body, in particular the liver. You can have patients developing diabetes because it's affecting the endocrine glands. It can contribute to some confusion based on involvement of the CNS, and can contribute to their fatigue. There are some iron chelation agents that are available. These all take a great deal of time. They are not without their own side effects, so you do need to really pay attention. There are some rare auditory and visual toxicities that can occur, so there needs to be baseline studies for that. In those patients who were fortunate enough to achieve transfusion independence and improve their baseline hemoglobin, we actually can consider phlebotomy, and that's the most efficient and quickest way to get rid of that excess iron. But for many patients, that's not an option, and we do rely on these iron chelation agents. So thankfully, there's been a lot of progress recently. Early on, we had, we developed among the MDS experts across the world, worked very hard. Dr. Peter Greenberg, who led most of this initiative in developing a risk stratification scoring system, the IPSS. And then we had three drugs, basically 2 hypomethylating agents, azacitidine and decitabine, and lenalidomide, an immunomodulatory agent, for years. And it wasn't really until we got further along in characterizing the disease and potential actionable targets using enhanced cytogenetic and molecular testing that we were able to develop newer compounds for the treatment of low-risk MDS, and now some exciting things happening in high-risk MDS, which you'll hear about in a moment. So this is a way to look at things. So as you heard in the previous discussion, I know some of the type here is pretty small, but for low-risk MDS, they have to have an IPSS-R score less than 3.5. And so we heard about Kathy. She's low risk. She was asymptomatic and then became symptomatic. And so, we're still going to monitor her counts frequently. Very important to look at historic counts and ask about the number of transfusions someone may have had. Once a patient is moving toward becoming transfusion dependent, you can actually initiate therapy, and you heard about that with Kathy's case, where she was started on erythropoietin stimulating agent, or EPO as we call it. Importantly, when you look at erythropoietin treatments, they are not effective in patients who have high erythropoietin levels. And erythropoietin is a hormone that we make in our kidneys. It's necessary to move a immature red blood cell across in differentiation into a mature red blood cell. If you have plenty of your own, erythropoietin giving you more of that is not likely to be beneficial. So really important to do that erythropoietin testing at the time of diagnosis, as you heard in the last session. But if they have other characteristics, isolated thrombocytopenia and platelets that are low without bleeding, we're going to offer that supportive care. We may offer thrombopoietin stimulating agents or eltrombopag or romoplastum. But ultimately, we're going to need to think about moving into a hypomethylating agent for those patients. If they have isolated neutropenia, so their neutrophils are low, and you really need to look at other etiologies. This is a less common subtype of MDS. Sometimes it's very difficult to make that diagnosis. You want to make sure you have a skilled hematopathologist reviewing that case. And then there are patients who have multilineage dysplasia, meaning more than one cell line. So it may be red blood cells, white blood cells, or neutrophils and platelets. And in these cases, you want to make sure you're not missing a diagnosis of aplastic anemia, certainly, but also you can in some of these patients use aplastic anemia-like therapies. And again, this is a very specific subset of those patients in the lower risk category. So let's talk a little bit about some of the newer drugs. I mentioned luspatercept. Luspatercept is a erythroid maturation agent. It's a trap ligand. Ligands are these proteins that stimulate downstream phosphorylation. And unfortunately, in some patients with MDS, there's this upregulation of something called SMAD2, SMAD2/3. And it basically inhibits that late stage erythropoiesis, so that final process of red blood cell development. And so it makes sense that if you have a drug, luspatercept in this case, that's going to trap that ligand and basically open back up that signaling path to promote normal red blood cell maturation. And so you basically are allowing that transmission that allows you to fully develop red blood cells. So the study that brought this to FDA approval was the phase 3 Metalis study, and this compared luspatercept with placebo. And so you see luspatercept in the dark blue bars and the placebo here in the orange bars. And importantly, transfusion dependence is defined as 2 or more units of transfusion over an 8-week period. So that is the definition of transfusion dependence. And then transfusion independence is just that, no transfusion for a rolling 8 weeks. So importantly, that's the sections here in this data over time. But you can see anywhere from greater than 8 weeks up to week 1 to 24, greater than 12 weeks, up to week 24. And then in the longer term study, greater than 12 weeks going out as far as 48 weeks, greater than 16 weeks at 24 weeks of analysis, and greater than 16 weeks up to 48 weeks. Across all those time points, this favored those patients receiving luspatercept compared to placebo. So that is showing efficacy. The most common adverse events with luspatercept or placebo of any grade occurring in more than 10% of the patients were fatigue, diarrhea, asthenia, nausea, dizziness, and back pain. So then we look at basically, again, long-term transfusion burden, and we saw some of that in the last slide. And I think what's really important to me here is that depth of response can improve over time, and the number of units administered over time was much, units of red blood cells, was much lower in the group on luspatercept compared to the group receiving placebo. And based on this, the FDA approved luspatercept on April 3rd of 2020, so almost exactly a year ago, for treating anemia in patients failing an ESA, those erythropoietin-stimulating agents, requiring 2 or more units over 8 weeks, the definition of transfusion dependence, in adult patients with very low to intermediate risk MDS, specifically with ring sideroblasts, or a subset of patients who have MDS-NPN crossover disease. And MDS-NPN crossover, these are patients that have features of both MDS and myeloproliferative neoplasms, specifically with ring sideroblasts and thrombocytosis, were found to have a benefit, a subset of patients found benefit with luspatercept. Some of the other things that are coming then, we have DNA methyltransferase inhibitors, which we talked about earlier, azacitidine and decitabine. These have been the backbone of disease-modifying therapy in both lower risk and higher risk MDS since their development in mid-2000s. And you can see here why that is. There was found to be improved outcomes when compared to supportive care, which at that time was all we really had for patients with MDS, whether low risk or high risk. More recently, both of those drugs are given through either infusion or, in the case of azacitidine, as an injection. And more recently, there have been oral compounds that are either now FDA approved or in continued clinical trials, really looking at, again, decreasing the treatment burden, allowing people to spend less time with us and more time doing the things they like to do. What you heard from Sarah so eloquently. So one of the most recently approved drugs is the oral decitabine plus cedazuridine in combination, and this was known in the trials as ASTX727. I won't bore you with the chemical structure because I don't really even know how to explain it, but it looks pretty on a slide. But basically what this did, one of the difficult things that happened in the early studies is we found that these oral agents were just not metabolized unless we got to very high doses that were then not tolerated as well. And so this was a very important study that used this compound with cytidine deaminase inhibitor, CDA cedazuridine, and allowed improved bioavailability of the oral compound. And so when given in combination, it enabled efficient oral availability. So this is the phase 3 ascertained trial, which basically showed bioequivalence of ASTX727 to injectable decitabine. And you can see here there were a number of CRs and overall response rate approaching over 30%. And based on this, the FDA approved ASTX727 for adult patients with MDS with a very broad indication covering refractory anemia with ring sideroblasts, refractory anemia with excess blasts, and CMML in intermediate 1 to 2 and high-risk IPSS groups. And then lastly, there is a phase 3 trial of CC486 oral azacitidine in RBC transfusion dependent lower risk MDS. And so this is something, again, where you see CC486 versus placebo improvement in transfusion independence of 56 days or more. Again, most common AEs were low-grade GI events in most cases, some more serious events with cytopenia specifically, and basically can all be managed very well with dose interruptions, dose modifications, and supportive care. Okay, so we know we have improved options with our currently approved therapies for patients, and you're going to hear about some of the exciting things that are coming in the next section here. But most of the patients will have anemia at some point over the course of their disease, and we have a number of choices here. In that lower risk population, we have ESAs still as a standard of care. We have lenalidomide, an immunomodulatory agent that is specifically considered in patients with deletion 5q, particularly as a sole abnormality. You can combine those two agents in some cases. And then more recently, we have luspatercept, which provides a new option for patients who may fail ESAs. For those patients who may have thrombocytopenia at presentation, even if low risk, we're going to really consider those DNA methyltransferase inhibitors in those cases that have been shown to improve thrombocytopenia. And that may be as a single agent or in combination. I think we always want to consider clinical trials for any of these patients so we can develop newer therapies. The investigational agent CC486 or oral azacitidine basically is not FDA approved for this indication at this time. It is not equivalent to parenteral azacitidine, but is being investigated in continued clinical trials. So here we are back to Kathy. And as you recall, Kathy is a 76-year-old woman with low-risk MDS. She has SF3B1 mutation, normal cellularity, 3% blasts, and she has greater than 5% ring sideroblasts. She's become resistant to erythropoietin-stimulating agents and is now requiring transfusions. So, Dr. Salman, what would your recommendation be for Kathy?
Yeah, so I think this is really quite a classic low-risk patient. The SF3B1, of course, clinically and molecularly typically meeting that profile. And so any patient that has that mutation and has at least 5% ring sideroblast does fit your MDS-RS. And so this is really the exact on-label FDA indication, for luspatercept. And what's nice is it's a very safe drug, and again, can lead to transfusion independence in 38% of patients. So I think it's a really good next option to consider. I think potentially down the road, lenalidomide with ESA, potentially hypomethylating agent, but first step, and I think for safety and others, I would use luspatercept based on its on-label indication in this setting.
Great. And Dr. Tinsley, anything to add on your part?
Yes, I think luspatercept is the next treatment that would benefit her. It's beautiful that it's just 1 milligram per kilogram initially. It's a subcutaneous injection given every 3 weeks. So I think that's a next treatment choice for her that will be good.
Okay, so to close off the low-risk MDS, I think, we really do need to educate patients about the risks of transfusions. Sometimes they feel like, that's a good way to go and may not understand the risks that are carried from that. Maybe they feel uncertain about some of these, certainly disease-modifying therapies or even supportive care options. So very important to talk with them about it, help them keep track of their transfusions, particularly if they're getting those at a center that's not affiliated with your clinic or your hospital. In many cases, they'll go to a outpatient infusion center to receive this, and you may not be as familiar with the number they've gotten. If they're spending half their year one place and half their year another place, that may also be difficult. So really important to empower the patients to keep track of this. And then in terms of setting expectations, really important once you start therapy for MDS, you have to give it enough time. And a lot of that is based on the mechanism of action. These are things that take time. As you saw, that transfusion burden can improve, continue to improve over time. So we generally commit to a minimum of 4 to 6 months unless they're not tolerating it, understanding that the best response may not be evident for even longer than that. And we may see some cytopenias in some cases before they get better. So I always say it may get worse before it gets better. And if they understand that, they're more likely to stick with treatment and perhaps have full benefit. And then the last thing is mild to moderate asymptomatic cytopenias are okay. All of their counts may not completely normalize, but if they're asymptomatic, that's okay. And now I'm going to turn it over to Dr. Salman.
So thank you for the introduction. There's quite a bit of data we're going to go over, but really just like to highlight from a big perspective what are the basic mechanisms of action of these agents, and really hope to shine some light that there is quite hope to really improve the standard of care for these patients, given we really have not had approval since 2006, as was stated earlier. So just to start this with a case. So we have a 65-year-old gentleman who presented with anemia. You could see has clearly high-risk disease, both by an increased blast count at 7%, and then actually has very complex cytogenetics, and particularly has abnormalities of chromosome 5, 7, and 17. Actually, even without the next-gen sequencing data, if you have these 3 abnormalities together, you could predict with actually almost 100% certainty that the patient indeed will have a TP53 mutation, which unfortunately, out of all molecular subsets, predicts for the various poorest of outcomes. As expected in a high-risk patient, it's quite heavily transfusion dependent as well. And so just thinking about, where we're at currently. So of course we have hypomethylating agents. Really, azacitidine has overall been the standard, and that's because that is the agent that has been the only one shown to improve overall survival, at least in phase 3 trials, although decitabine is also approved in this indication. We always want to ask the question up front, is a patient fit or not fit for an allogeneic stem cell transplant? And although it can be considered to be utilized as first-line therapy, maybe particularly in patients that have lower blast, in general, almost all patients will get an HMA therapy. Although really, and I think what I'm going to try to stress is highly considering trials, both if they're a candidate or even if they're not a candidate for transplant. A little bit beyond the scope would be sort of options based on resistance and others. Again, we're going to focus on the frontline setting. So there are really a ton of agents that are in active investigation MDS from phase 1 to phase 3 studies. These include immune therapies, targeted therapies, and others. And again, really going to focus on agents that are the most farthest along in the setting of frontline therapy, although I would say there are others that, again, we just don't have time for in this presentation that are also looking quite exciting as well. So now we're going to move into the mechanism of action really of each agent, and then really a brief overview on the outcomes and efficacy and safety for these agents. So first I'd like to discuss magrolimab. It's the agent I've been working with quite closely over the past several years. So it's a first-in-class anti-CD47 antibody. So basically CD47 is increased expressed on these cancer cells or leukemic stem cells. It tells the macrophage to don't eat me. I like to explain it to my patients like Pac-Man. And importantly, the cancer cells have pro-eat me signals, but again, the CD47 blocks it. And thus adding magrolimab eliminates this signal, allowing for rapid induction of phagocytosis. Importantly, healthy cells don't express pro-eat me signals, and this really largely allows for selective elimination of cancer cells. The one notable exception are old red blood cells, and thus we do see on target and particularly first cycle anemia with this combination, but we mitigate that both by keeping them at a higher hemoglobin. I actually keep my patients above 8.5 to 9, at least through first cycle, as well as a mitigation strategy by starting with a very low dose of magrolimab that gets worked up over the course of several weeks. These are the data we most recently presented at ASCO. You can see 33 patients with a vast majority of patients responding, a true complete remission rate of 42%. And you can really see in the waterfall plots on the right that nearly all patients are having some level of blast reduction. I think really just looking at response by itself is not enough. You really want to look into the quality of the response, particularly are we improving patients' counts, as that's clinically what they're feeling. Notably, about 60% of patients do achieve transfusion independence, and we're seeing nice depth of remission with a subset of patients both achieving complete cytogenetic response as well as by multiparameter flow cytometry patients achieving MRD negativity. And I think really what's as important as anything is how durable are these responses, at least at last data cutoff, although the follow-up is still somewhat short. We have not met a median duration of response. And again, the combination has been very well tolerated. We're not seeing immune-related adverse events with traditional immune checkpoint therapy that you guys are all aware of, such as with pembrolizumab or nivolumab. Again, really just on-target anemia that improves over time as patients are responding. I'd like to next switch into an agent that probably the vast majority of this group is familiar with, Venetoclax, which of course is approved with azacitidine or decitabine in elderly acute myeloid leukemia, but is being tested in MDS as well. Again, as a brief overview, there are a number of pro-apoptotic proteins that should overall support apoptosis, but this is blocked by the anti-apoptotic protein BCL2, and Venetoclax specifically and selectively targets that overall to induce apoptosis in the cell, and has been shown to be synergistic with azacitidine. So in the MDS data, these were most recently presented by Jacqueline Garcia from Dana-Farber at ASH of 2020. You could see, again, a very high response rate of nearly 80%, with 40% of patients having a true complete remission. These responses are occurring quite quick and actually have very nice depth as well. with a number of patients, again, over 60% of patients achieving transfusion independence. I think the one thing is that the combination is quite myelosuppressive. It requires a lot of personalization from the entire medical team. And so, for example, in MDS, Venetoclax is dosed only on a 14 out of 28-day schedule, even from cycle 1, with many patients requiring dose adjustments as well. So it's not something you can just do continuous, but again, it is a therapy that is synergistic thus far in early clinical trials. Next, I'd like to move to a drug, maybe the most complicated one to explain from a mechanism of action perspective, but is pevonedistat, which is a NED8 activating enzyme inhibitor. Essentially, inhibiting this enzyme leads to the accumulation of many proteins. This is because it ends up blocking an ubiquitin ligase, which typically targets proteins for the proteasome. This accumulation has a sort of a wide array of effects, and which one is most important, I think, is still work in action, but ultimately leads to an inhibition of DNA replication, cell cycle arrest, and ultimate induction of apoptosis. This trial has been studied quite extensively. These are showing some earlier data in phase 2 study of pevonedistat in combination with azacitidine. Again, it's been tested in both MDS as well as CMML and oligoblastic AML patients. I think what's notable is, with somewhat more of a mature follow-up, is that the event-free survival is statistically significantly improved in higher risk MDS patients. I think the study is not powered for overall survival, but you can see somewhat a similar trend. What's nice is the combination has been very safe, with really no significant increased toxicity over azacitidine alone, and you can see going along with that a significantly higher percentage of patients having transfusion independence. Again, now almost 80% of patients are having a response, a true complete remission rate of near 50%. Again, much higher than what we would expect from azacitidine therapy alone. Sabatolimab is a novel immune therapy, has a dual mechanism of action in that it can both target the leukemic stem cell as well as targets sort of the negative immune checkpoint on T cells. So it's both an immune activating agent as well as a specific leukemic stem cell target. Some early phase 1 data, again, were just recently presented in MDS patients at ASH of 2020 by Dr. Bruner. Again, you could see an overall response rate of 60%, although a true complete remission rate is somewhat low at 23%. I think what's most critical with this agent is ultimately what the durability of this response and longer follow-up is needed to really see what that will be. Again, overall quite well tolerated. We do see the sort of standard cytopenia toxicities. Immune-related adverse events have occurred, but overall they have been low grade and can be managed in the vast majority of patients. And lastly, just talk about a p53 specific agent, APR-246 or eprinetopop. This is actually a first-in-class p53 reactivator. It's actually a prodrug which under physiological pH is converted to MQ. MQ then binds both the mutant p53, refolds it to allow a more wild-type shape to induce apoptosis, although notably it does have p53 independent action, predominantly through the increase in reactive oxygen species. This large phase 2 study has just been recently presented by our group as part of the MDS consortium in JCO, and you can see a very high percentage of patients, near 90% of patients responded, with a true complete remission rate of 50%. I think one setback has been in the randomized phase 3 trial, which was recently press released. The complete remission rate was not improved, although there are many trials ongoing in AML as well as maintenance and others, including a second generation inhibitor, p53 reactivator, APR-548. And thus I still think there is significant hope for this agent, but we really have to look at this further. I think with all of these clinical trials, I think the response rate is quite high. The durability are key questions, but importantly, all of these agents are now in randomized phase 3 trials to really definitively prove that we have shifted the standard of care over HMA therapy alone. And again, I think it's quite promising, and I think really critical that we're seeing not only response rates, but higher transfusion independence, overall well tolerability, and really as much as possible, ideally to get as many patients across the US into these trials as we really hope to move the bar forward. So with that, I'd like to shift us back to our case and definitely get some insight from the other faculty members here. So again, this is a very high-risk P53 mutant patient that is clinically symptomatic. And so maybe Sarah, if you'd like to start, how would you approach this patient? What would you be thinking about?
Well, first I would tell him you have a pretty serious high-risk MDS that's difficult to treat, but we do have options for you if he wants to be treated and see what his goals are. But I think the best route for him, with what we're looking at, would be a clinical trial if he's interested in being treated and moving forward.
And Sandra, any other thoughts?
No, I mean, I agree. We always, prefer a clinical trial because that's the only reason we're having this conversation about these new drugs. But he's 65 and could be considered for transplant if he responds to, some preparative therapy. So that would be the question, is how best to bridge him to transplant given the presence of TP53. Perhaps a combination with Venetoclax.
Yeah, I think your last point is a really good point, meaning that the depth of remission. I think we and others have shown that if you can clear the P53 mutation, that's probably the subset of P53 that has a potential benefit to have improved outcomes with transplant, where if you haven't, really the outcomes to transplant are quite dismal. And again, I think all of these trials, a lot of the subsets are small. I think the agents that have looked the most at P53 are magrolimab and, of course, the P53 specific trial with APR-246 and maybe APR-548 in the near future. But there have been responses reported across all of these agents. And so I think, the phase 3 trials need to read out, as well as maturation of some of the other current trials. But again, as all of us have described, really encouraging and educating patients. They are making a big sacrifice from time, but we're really hoping that their outcomes will be, quite significantly improved. And I believe we just have just a couple more slides. Any other points that we think we should bring home for the audience, either from a nursing perspective or any other that you think are relevant to bring up for our considerations of MDS management?
Well, I think the nurse's role really in helping patients stay safe on these therapies can't be overemphasized. The nurses help encourage them, help monitor their labs, set up transfusions, educate them on neutropenic fever, thrombocytopenia, and are there for them as a support, So I think...
And I would just add, being otherwise well, really helping people not only mitigate their adverse events, but being as well as they can be so that whatever that next option is, it's an option for them. And really emphasizing, that fact.
Yeah, totally agree. Yeah.
Yeah, I agree with all of these points. I think it really takes a team, and not just the team at the academic centers, but particularly in the community. I really see as treatments for our patients are becoming extremely personalized and really require titration from side effects to medications and everything else. Really working as a team, having their consult with us, but ideally, ultimately getting these patients treated back in the community, ideally on study, if at all possible, through those collaborations. And again, really hoping we improve both the quality and quantity of these patients' life. So I think this has been a great discussion. I want to move it back to Dr. Tinsley, maybe for just some reflections and to move us into the question and answer session.
Yes, so thank you all for joining us. I hope you learned a lot that you can share with your patients. And with that, we'll take some of your questions and hopefully help you with some of the things that you have concerns about.
So we have a number of questions that have been asked. I think, Sandra, one is really directed to you to start. So the question is there any data to show an increase of the risk in pulmonary embolus with luspatercept If so, was it seen at certain doses? But maybe any commentary on that, Sandra, would be great.
Sure. So I think it's important to know, and in any drug, when you're looking at a package insert, that it may have more than one indication, and that's true for luspatercept. So not only was it studied in myelodysplastic syndrome, but it's also been studied and can be used in beta thalassemia. And so there were some thrombotic events that did occur in those patients with beta thal, and as a result, there is a warning. I guess I would just add that if you do have an MDS patient that has very high risk features for thrombosis, or maybe has had a history of thrombosis, you would just want to implement safety measures to reduce that risk.
Yeah, no, I think that's a good point. I almost wonder, with ESAs, of course, we have had similar risk, and if it's based on the degree of hemoglobin, I think, real world experience may tease some of that out.
Yes, and there are dosing guidelines for luspatercept relative to the rise in hemoglobin, very similar concept.
Right. And maybe for Sarah, so there's basically a question on, when can low-risk MDS patients switch from blood transfusions to luspatercept? But I guess maybe a little bit of the discussion point of when do you think of transfusion support alone versus active therapy, and maybe how that shifts both the start of treatment as well as at later time points?
That's a really good question. I think that when a patient is needing transfusions, that becomes transfusion dependent, not just one transfusion, but they have a pattern of needing transfusions, that's really a time to think about starting them on some form of active therapy. And the first thing we would do for a low-risk patient is check their erythropoietin level and see if it's less than 500, then we know it's time to start them on some erythropoiesis stimulating agent. And then once that fails, then you move down the line. We normally will recheck a bone marrow biopsy to make sure that their disease hasn't changed. And then move, if they meet criteria for getting started on luspatercept, you don't want to wait until they've had lots and lots of blood transfusions to start them on therapy. So I think paying close attention to your patient and really checking, getting them involved in keeping track of how many transfusions they're receiving and at what interval, and keeping track of their ferritin too, making them aware of that. Because sometimes you have patients that don't want to change what they're doing because they feel totally comfortable with that. But emphasizing that lots of blood transfusions aren't good for you in the long run. So I don't know if that answered it.
Yeah, no, I think that was a great discussion. And then there's kind of a third question maybe I'll take, but sort of how to care for patients with high risk MDS and manage therapy related toxicities. I think I kind of went through it quite rapidly, and some of this we have discussed. But I think one big difference is with azacitidine you kind of you gave it for up to 6 months, and you sort of, they're on this 28-day cycle. Yes, there is toxicities, but you kind of watched it and you said, well, we have to get at least there, if not longer. I think that paradigm is changing with combinations. So bone marrows are going to be much more frequent early because a lot of times you may be able to stop the toxicity, for example, with Venetoclax. If they clear their blast, we know if we hold it, they can usually recover their counts quite rapidly. And the sooner they recover their counts, the sooner they're out of the dangerous zones related to neutropenia, thrombocytopenia, and typically the better they feel. I think with these other agents, we know that responses are also more rapid than with azacitidine therapy alone. And again, titrations and active management are key. And then each agent, again, is somewhat new. And there may be very unique side effects that we're not capturing in trials that we may capture sort of in the real world experience. So again, I think it's going to be a much more, one-to-one, nurse, physician, everybody, together to help these things work. Because if I think a lot as these new agents are coming about, if there's not this sort of micromanagement, patients don't get that full benefit that they really may get if they're optimally managed.
Thank you so much for joining us. Thank you, Dr. Salmon and Dr. Curtin. We really want to thank the audience too for being a part of this presentation. We hope that you learned a lot that you can share with your patients and with your colleagues.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/EQN860. This activity is supported through educational grants from Bristol Myers Squibb, Gilead Sciences Incorporated, Novartis Pharmaceuticals Corporation, and Takeda Oncology.